And we're ready for our lunch and learn. Our today's speakers are Drs. Herold and Dr. Habib. Thank you.
All right, we'll go ahead and get started. All right, so our objectives today is we're going to review some clinical features and pathophysiology of myocarditis, proposed mechanisms for myocardial injury in COVID-19, myocardial injury in pediatric patients with MISC, and then what we know regarding myocarditis and inflammation in young athletes, and then a return to play algorithm based on what we know. The World Health Organization has criteria for myocarditis is inflammatory disease of the myocardium, diagnosed by established histological, immunological, and immunohistochemical criteria. That would make biopsy as the gold standard for diagnosis. The incidence in adults is about 20 cases per 100,000, and in children it's anywhere from 0.3 to 2 cases per 100,000. As you can see in this graph, there's a bimodal peak in infants and teenagers. We estimate it probably accounts for up to 20% of SIDS cases, and according to NCAA data, it's estimated to cause about 12% of sudden death. That number is significantly lower in children, somewhere around 5%. So here's a giant diagram with all the potential etiologies of myocarditis. We're going to focus primarily on viral agents. As you can see, the top players here, Coxsackie B virus, one of the enteroviruses, has historically been the most common cause. That's slowly being replaced down to the number 2 slot as Parvo V19 is actually taking the top spot moving forward. But what you'll see is that coronavirus isn't really even listed in the top 5 of known causes. This is a model of pathophysiology related to Coxsackie virus, and there's 3 phases to the inflammatory process. So the initial process is in cardiotropic viruses, they do direct viral entry into cells with immediate viral replication and lysis of myocytes that lasts over the first 1 to 7 days. That lysis also causes an innate immune response. Phase 2 is between 1 and 4 weeks, where we get cellular and humoral responses with adaptive immunity that causes mediated cell injury. First, there's natural killer cells, then macrophages, and then infiltration of T cells, which peaks around 14 days, which is the highest amount of inflammation. Phase 3 is sort of a convalescent recovery phase. It occurs over months to years, and that's typically where we get clearance of the virus with myocyte degeneration, fibrotic changes, and sort of long-term remodeling. We used to use kind of the rule of thirds, but in reality, it's kind of the 50-25-25 rule, where 50% of the cases are going to improve back to baseline. About 25% will be sort of left with where they are at the time of initial infection with low ejection fractions, and then another 25% will continue to deteriorate and ultimately require transplant. So there's a couple of different working case definitions for myocarditis. Obviously, we can't do endomyocardial biopsy in all patients. There's a couple of different criteria. World Health has one. The European Society for Cardiology has another. But basically, this is around doing more non-invasive testing and look at clinical presentation. So when you see in our probable cases and confirmed cases, we need to have 1 or greater new or worsening clinical symptoms as listed here. Age appropriate in kids less than 12 with irritability, vomiting, poor feeding, and lethargy. And then in the probable case, an abnormal elevated troponin, abnormal ST, ECG, and ST changes. Also on here that I didn't list is abnormal function or wall motion abnormalities on echo, and then CMRI findings consistent with myocarditis should be in this list. And that's in the setting of no other identifiable cause of the symptoms. In the confirmed cases, it's all the same with the addition of the histopathologic confirmation of myocarditis based on Dallas criteria, and then abnormal troponin with MRI findings consistent with myocarditis. And those are based on Lake Louise criteria, which are it's a 3-part criteria using T1, T2, and late gadolinium enhancement. If you've got 2 or out of 3 of those criteria, there's an 80% diagnostic accuracy for myocardial inflammation. And we'll talk a little bit about that later. So going through the kind of the three patient groups that we know about with myocardial injury, we're really unsure whether the myocarditis related to COVID is an indirect complication or a direct manifestation of the virus. And again, we're not, while we do see that it is probably a cardiotropic virus, when we look at some of the studies in adults, we'll find that actually getting viral material from myocytes hasn't really been seen very often. In hospitalized adults, cardiac complications were seen in up to almost 30%. So if the overall case fatality rate in patients overall is around 5%, if they had myocardial damage, that case fatality rate for that small subgroup went up to 50%. Obviously, we know about the poor outcomes with pre-existing cardiac comorbidities. In a study in New York with 257 critically ill patients in the ICU, 82% had at least one cardiac comorbidity. The most common of these was hypertension and obesity, with diabetes and underlying heart disease rounding out the top four. So the COVID-19 pathways related to myocardial injury in adults, we think is kind of 5 different things. The first is the binding of the S spike protein to the ACE2 receptor. So that's going to downregulate that receptor, which is going to increase angiotensin 2. That leads to a whole host of things, including vasoconstriction, inflammatory process, and then procoagulation. All of those also lead to the cytokine storm, which we like to talk a lot about, and also applies to MISC with increased interleukin and tumor necrosis factor. We see the increased cytokines mediating lung injury with alveolar damage, pulmonary edema, and ARDS, and then that same storm can lead to multi-organ failure. Activated macrophages can actually get into the endothelial cells and cause plaque rupture. We also see a prothrombotic state, as well as direct viral damage to endothelial cells themselves, and then tissue hypoxia, sort of related to the mediated lung injury, causing not just heart damage, but multi-system damage as well. In those adult patients that presented who did poorly, it presented as 5 different things. One was myocarditis as diagnosed by the prior criteria, underlying heart failure, malignant dysrhythmias, acute coronary syndrome, and Takotsubo syndrome, which is sort of a shock cardiomyopathy. So the problem is differentiating between true myocarditis and myocardial injury in adults has been difficult, and so most of it's been on indirect testing and presentation. When multiple systems are affected, it's hard to figure out what's the cause. And then in these critically ill patients with myocarditis, we can't really do things like move them around the hospital to the cath lab to go get into myocardial biopsy, or take critically ill patients to get a CMRI because of how sick they are. On the flip side, when we have younger, healthier patients that we suspect of a clinical diagnosis of myocarditis, we typically aren't going to take them to the cath lab to do a biopsy, and often if they recover quickly enough, we may not send them to go get a cardiac MRI. Here at our own hospital, we have an additional difficulty in trying to get a cardiac MRI, and young people has a few more hurdles to it. So 2 studies looking at autopsy data in adults that had myocardial injury. In this one from Hopkins, almost all of them had one or more cardiac comorbidities, an estimated incidence of myocarditis in 7%, but then we went on and reviewed path data, and the incidence based on immunopath was only less than 2%. In Birmingham, they looked at an additional 50 autopsied hearts. They only saw lymphocytic infiltrates in 16%, and focal myocarditis only in 4%. And most of them didn't have, despite all these inflammatory markers and elevated enzymes, very few of them had inflammatory infiltrates or myocyte necrosis. The study that gets cited the most is this sort of long COVID in adults. Is this study out of Germany, looking at 100 patients, where only 33 of them required hospitalization, and the rest of them were COVID positive and convalesced at home. They did CMRI and troponin measurements at around 2.5 months after initial infection, and 78% persisted with abnormal CMRI findings consistent with myocardial inflammation. We're not seeing a lot of primary myocarditis in kids related to COVID. Primarily, this is presenting to us as MISC. Part of this is that there's much lower disease severity in pediatric patients. with only 30% of children with clinical manifestations versus over 60% in adults. Children are comprising a much lower number of hospitalizations, although we reached a new milestone today with about 1,500 hospitalizations across the country. And then in the early Chinese data that had 2,000 pediatric patients, only 5% had severe disease with hypoxia, with only 0.6% with critical disease and multi-organ failure. So just brief data on MISC. It was first described in UK in April 2020, although in the Italian outbreak, they had a large retrospective number of folks diagnosed with atypical Kawasaki's disease that was probably MISC. As of a few days ago, there's been just over 4,000 cases in the US with 37 deaths. And as you can see, if we've got primary COVID outbreaks here, the peak of MISC is around 4 weeks after those initial peak outbreaks. The most common comorbidities in kids are obesity and asthma. And then congenital heart disease does not appear to be a risk factor. Most of the represented cases are Black or Hispanic patients with a median age of 9, which is much older than the Kawasaki disease cohort. And while the majority are serology positive, very less of them are PCR positive. As opposed to primary cardiotropic viral damage, we think this is a hyperimmune response in a genetically susceptible child with a significant number presenting in shock. So you'll see that this is a very similar slide to the primary, except it doesn't have that initial cardiac myocyte invasion. We think it's more of a dysregulated inflammatory response resulting in endothelial injury and then microvessel injury resulting in ventricular dysfunction and then coronary artery dilation, as well as conduction abnormalities. This was a macro review of all of the available MISC reports showing that 50 to 80% of these kids presented in some form of shock. A significant number have had incomplete Kawasaki's disease criteria. A significant number had left ventricular dysfunction and elevated troponin, as well as a BNP, which we're seeing often. Very few of them got a cardiac MRI, so that we don't really have any data for these kids. And the same is true for cardiac CT to look at coronaries. This is a further breakdown of LV dysfunction. In the red and the blue, the Valverde and the Tubiana studies, LV dysfunction was necessary for inclusion in the study. So that 100% was going to be expected in those. But we see a significant amount of LV dysfunction overall with a much lower incidence of coronary artery dilation, but it's still significant. In terms of long-term outcomes with MISC recovery, we see 35 patients in 14 centers. This number had an EF of less than 30. A lot of them required support, had normalization of LV function in over 2/3 with no deaths. In this one, we had 80% of patients with normal function at discharge with 1 death. And then a 6-month follow-up, 33% had abnormal echoes at presentation and abnormal biomarkers, but at 6 months, 96% had normal echoes and 100% had normal function and cardiac biomarkers. Interestingly, a significant number had an abnormal 6-minute walk test. So our COVID return to play in our college athletes, which has really been where the focus of a lot of the research has come. There's 500,000 collegiate athletes with 8 million high school athletes each year. In the NCAA data, that myocarditis incidence is up to 12% cause of sudden death, but there have been no published reports of death in athletes from COVID-19 related myocarditis, not primary COVID, which there have been a few reports. The initial report that kind of scared the majority of people was a small study out of Ohio State, where 15% of those athletes screened had abnormal MRI findings consistent with myocarditis. 31% had late gadolinium enhancement consistent with prior myocardial injury, and that prompted the doctor at Penn State to put that statement out where 30% of the athletes had 30%, which immediately shut down Big Ten football. But they uncanceled it in October. So the studies that we have for athletes, the first was in professional teams, had about 800 patients, where the incidence of myocarditis was only 0.6% based on abnormal MRI. Now, they took abnormal screening, the triad of echo, ECG, and troponins, and then that led to 30 of those athletes getting the MRIs. In Tennessee, those patients, the majority of those patients were symptomatic. with up to 33% of them having moderate symptoms. Small number of them had an abnormal troponin, but only 5 athletes referred for MRI based on abnormal screening had 0 evidence of myocarditis. A larger cohort of 3,000 athletes in a collegiate registry of about 60 colleges looked at triad testing, the same thing with troponin, echo, ECG, and if those were abnormal, they referred them for MRI. They also took an additional nearly 200 patients and just did MRI in those. Overall, the myocardial involvement was around 0.7%, but not to be outdone, the Big Ten, mostly Ohio State, came back with their study of over almost 1,600 athletes and found a abnormal MRI in 2.3%. So the suspected incidence of myocarditis in these athletes, with a significant number of these being 75%, was a bit higher than in the other studies. And the scary thing that they put out there was that 54% had no symptoms in normal screening tests. The issue with the myocarditis and MRI in these athletes is that the Lake Louise criteria for myocarditis has only been validated in symptomatic myocarditis. Those people coming in heart failure, sick as stink, that maybe they get an EMB and then they go get an MRI to look at that. We don't have a validation for CMRI in asymptomatic patients with suspected myocarditis. So it's really unclear if these MRI findings correlate to an increased risk for sudden death in these athletes, especially if they have no symptoms. The question that's been posed is, are there similar MRI changes in other viral illnesses like influenza? And I think there'll be some studies coming down the road looking at that. So we'll switch gears, and Dr. Habib's going to take over, talk about return to play.
Hello, everyone. Thank you guys so much for coming to our talk, and thank you, Dr. Herold, for giving that rousing, wonderful presentation. Just to let you know, I'm completely the appropriate person to be talking about this. I was a varsity math team athlete, and I was on the varsity computer team, so completely the right person to tell you all about sports and return to play. So just a little bit of humor to start us off, because I'm sure this is how we all feel during our Zoom meetings. But mainly, I wanted to talk about our COVID effects on athletes. As I was combing through the data on the internet and looking at the literature, I came across a lot of things that were kind of interesting, that were not just basically the little cardiac subset of the world that I live in. First of all, we've got patients with primary COVID-19 infection. That might be respiratory symptoms. We've also got MISC with myocarditis. That lives in the world of cardiology. Other things, though, I think we need to consider are deconditioning from inactivity, increased stress and anxiety from being away from play, which is affecting patients. The literature talked about that. Neuromuscular recovery, autonomic dysfunction, which we won't touch on a lot today, but Johns Hopkins has a very nice clinic that deals with this. Pulmonary symptoms, again, that ties into primary COVID. Fatigue, just because you're tired, you've been out of play, or you've been sick. Cognitive dysfunction, and then interestingly, talking about coagulopathies and DVT, PE, patients who are having, interesting symptoms of like significant unilateral leg swelling, pain, stuff that we see kind of more in the adult world. So this here, basically, we're talking about, so why do we even bother screening? This also just parlays into a conversation about why do we screen athletes in general, but what are we doing? We're trying to prevent sudden death, we're trying to prevent injuries, we're preventing worsening disease exacerbation, and also there may be legal and insurance sports team requirements to play. This is taken from M. Crawford, Screening Athletes for Heart Disease from Heart in 2007. Screening or clearance. So as I come from the adult world, partially, we don't necessarily say clearance, we'll say risk stratification. What am I trying to do? Say that you're low risk of any cardiac issues happening that we can play. So that's where screening comes from. You have to make a careful decision looking at all risk factors involved, not just the patient's cardiac disease, but also the sport that they're playing, how much the intensity is, who the other athletes are, and looking at it as a whole. These may be shared care decision making in some cases, like long QT, hypertrophic cardiomyopathy. That's a discussion for another day. Opinion regarding restriction has kind of changed somewhat in the modern era of pediatric cardiology. Back in the day, I think with a lot of congenital heart disease, we didn't know what to restrict. And now I feel like practice pattern, it takes a lot for a pediatric cardiologist to say we're going to restrict you from sports and change your normal life and your normal pattern. We're restricting, so we're preventing sudden cardiac death, worsening injury, induction of arrhythmia, or worsening of other non-cardiac diseases, right? Asthma, musculoskeletal stuff, neurologic problems, etc. Cause of sudden cardiac death in athletes, Dr. Herold touched on the NCAA data. I just thought another interesting little table here that I found that said about less than 5% of myocarditis in young athletes. I think this is more so talking about probably the high school population. So it's not really a very big amount of patients that we're dealing with here. This is just general athlete sports screening. How do we perform this? Our fantastic PCPs in the community are doing this 14-point AHA screening. It was revised from like a 12-point screening in the around 2014. These might be the same questions that are on the sports physical form actually, and these are really it's designed to identify patients with congenital or genetic heart disease, again, like long QT or hypertrophic cardiomyopathy. Interestingly, there's no real routine recommendation for EKG screening or pre-sports cardiac evaluation in the United States. There's other countries that may have something like EKG screening, like Italy, for example, but that also, I think, parlays to a little bit of litigiousness and just different standards in those countries. But as far as the US, there's no routine. This is just the AHA 14-point screen. I broke it up into a couple different screens for you. So you're getting their personal history, you're getting their family history, and then you're also examining them on top of that. Personal history, you know, your general cardiac symptoms, chest pain, discomfort, tightness, pressure related to exertion. I get a lot more worried if I hear that you are having chest pain with active exertion, not after you're stopping and resting, but during active exertion. Your heart should not just go, no, I'm not going to work and I'm not going to function when I'm in the middle of the field, peak speed, pedal to the metal. Unexplained syncope or near syncope. Yes, I know some of our athletes may have some vasovagal kind of stuff, but true unexplained cardiac syncope, they're fainting, they're not waking up. You might be doing CPR. It's not just a 10 or 15 second and they come out of it. They're really out of it. Excessive exertional unexplained dyspnea, like are you actually having shortness of breath with exercise? That means that you have cardiac failure, basically, like congestive heart failure. Prior recognition of a heart murmur, elevated systemic blood pressure, prior restriction from sports for whatever reason, prior testing of the heart ordered by a physician. Some of this, again, is just general PCP stuff that they're trying to evaluate. Family history, this is kind of where I think it gets a little bit interesting, where we talk about like premature death. I have a lot of patients who will come and they'll say, oh yeah, well I died, so-and-so died from such and such reason. Was it really truly sudden cardiac death? Sometimes it's a little hard to parse out unless you actually have an autopsy report. But regardless, anybody under the age of 50, that's where we've called it. Disability from heart disease in a close relative, less than 50, any kind of cardiac physical exam findings, as we mentioned here, like blood pressure. This was just an interesting article that said, how good is this screening versus EKG? Basically, patients will answer positive to a lot of stuff, and then after physician review, the numbers of the amount of stuff they've responded positive is decreased. So which is why it's really nice and helpful when our primary care providers are able to go through those forms like they do and really look at the details. Now we're getting a cardiovascular screening for actual athletes and return to play with COVID-19. This is from a paper out of Atlanta, Jay Kim, looking at recent guidelines. This was published, JAMA Cardiology 2021. Screening for return to play, as delineated in the original ACC report, is designed to identify athletes at high risk after COVID-19 infection, meaning anybody with myocarditis. Really, that's how I read that, and risk of sudden cardiac death. That is how I am taking that. We don't advocate for risk stratification for anybody who was completely asymptomatic. So you had COVID, you had a primary test and nothing, no symptoms, and you want to go back to play. That does not count. This is just taken from that same paper, telling you that there's already published guidelines for myocarditis recommending that being out of competitive athletics for 3 to 6 months. We've all kind of done the whole COVID thing to ad infinitum, but here's COVID symptoms and severity definition. Asymptomatic, like I mentioned, no symptoms. Minor low-grade temperature, like less than maybe 100.4 temperature, less than 4 days. Mild symptoms, mild nasal congestion. They really have not included like lots of taste and smell in the moderate symptoms. So moderate, persistent fever, 100.4 or higher for at least over 4 days. Persistent fatigue of 7 days duration. You might have pneumonia, chest pain, not associated with cough, activity limiting dyspnea. This is probably where the 6-minute walk impairments come in. Severe, where you're dyspneic, hypoxic, you need intubation, you need to go to the ICU, you need to actually be admitted to the hospital for a severe ICU related illness. And then severe and critical, this was taken from Up to Date, but severe and critical, that's kind of the same in my mind. The ACC recommendations, this is just a table taken from the ACC mentioning basically what Dr. Herold said. Routine cardiac MRI is not recommended in these patients because we honestly don't know how that's going to help us with asymptomatic patients. And there's really a wide range of what can happen to athletes with COVID-19. What we're really focusing on trying to get patients stratified who have concern for myocarditis and something life-threatening. On the internet, I found about 800 different tables of how to risk stratify stuff and how to, like, everybody had their own little algorithms. I thought that this was the nicest, cleanest algorithm that I had seen. This is from Mercy Children's Mercy Hospital, I think in Kansas. But so if you follow this decision tree, I really, really like how this is written. So let's talk and walk through with a patient. Okay, I've got an asymptomatic patient or a mild case, positive testing with no symptoms, less than 4 days of fever. What should I do? Okay, I need to at least contact my PCP and ask them and let them know, hey, what's up? This evaluation for return to play, by the way, does not start until 10 days after a positive test. They have advocated a period of exercise abstinence for 10 days after you have a positive test. And as far as symptoms, you need to be 10 days out of symptoms, but that may include, I saw different things that said, make sure you're off of antipyretics. Then I saw some things that said you were okay with antipyretics. I think just basically 10 days without symptoms. So athletes should contact their PCP if you've got mild symptoms, any respiratory or cardiac concerns, then you may need an actual visit. Okay, so if you have moderate symptoms, greater than 4 days of fever, greater than or equal to 1 week of chills, lethargy or myalgia, but not an ICU stay, see your pediatrician. They recommend from the ACC AAP getting an EKG. In our clinic, you may have to get a referral to get an EKG, but there may be some outlying centers like Radford or other hospitals where you can just order an EKG. So if your PCP evaluation and the EKG are fine, then you're good to go. But if your PCP evaluation of that AHA screen is abnormal, or this EKG is abnormal and is concerning, then you get bumped to seeing a cardiologist. So really you're talking about moderate issues where you have some kind of abnormal physical exam finding, EKG screening, or history question that is very concerning that gets you bumped to seeing a cardiologist. And anybody with severe disease, ICU level stay, MISC, intubation, they're automatically going to be seeing a cardiologist anyways. These are just pictures of the return to play algorithm. I might be running a little short on time. Basically, the main point is return to play evaluation is really going to be started after 10 days of isolation and no exercise. If you have myocarditis signs, you're seeing cardiology. If you don't have myocarditis, and then you look at, is this severe versus moderate disease, and what are my symptoms? You have to take into account also that if a patient has been having continuous symptoms for 4 to 6 weeks and they have COVID and positive testing, that may be primary COVID or MISC or some COVID related issue. If they haven't played for 6 months and they're getting back to play and they're tired, that's probably deconditioning. So I think really trying to pay attention, is this just my kid is deconditioned? And we have some return to play guidelines that have come out as well about how do we actually get people back to doing activity. A lot of this is just, hey, we have to have an approach for every athlete, look at their disease processes, look at their illnesses. The British Medical Journal is the one that really kind of put this into practice, and they made this GTRP, Graduated Return to Play Protocol, which basically they call it 6 stages. The AAP calls it 5 stages. Basically, this stage 1 or stage 0, no rest. No, I mean, all complete rest, 10 days of doing nothing, exercise abstinence, even if you have like mild, moderate, severe COVID, just do nothing for 10 days and rest. And then they talk about getting back to light activity and then getting into different stages. I've broken it down in a different way. This is from the AAP itself. So 10 days have passed, you're already over your illness, stage 1. Day 1 and day 2, minimum 15 minutes or less of light walking. Day 3, 30 minutes of activity. Day 4, 45 minutes or less of activity. Day 5 to 6, 60 minutes. Day 7, return to full participation. Everybody basically has said that, like, really, you don't go back to full participation The fastest track that you can get here is day 17 after having a positive test. So that'll be 10 days of rest and then 7 days of this. But each athlete, you might need more time, you might need less time. The important thing is when they're doing this return to play, looking for if they have symptoms. And we're talking about true cardiac symptoms. Again, chest pain with activity, shortness of breath out of proportion to having an upper respiratory illness, new palpitations or heart racing, new syncope, exertional cardiac symptoms, dizziness, edema, like heart failure symptoms, significant fatigue, not just I'm a little sleepy and resting, but man, I can't even go like a block when I used to go like 10 blocks before. I've broken this down from the AAP recommendations, asymptomatic or mild symptoms over here at minimum phone visit, do 10 days of rest, and then you can go back to play. Gradually, moderate symptoms, greater than 4 days of fever, myalgia, chills, lethargy, or just a hospital stay, but not in the ICU. You need physician clearance first by the AAP recommendation. Use your AHA screening. Get a screening EKG if you think that you need one based on their symptoms. That's not always necessary, but basically if you think you need an EKG, then you get one. If no cardiac symptoms or negative screening, meaning no symptoms, no EKG issues, then you can go ahead and return to play. If any of these things are concerning, that's again where you bump to seeing a cardiologist. Severe issues are given MISC, myocarditis, ICU stays, intubation, heart failure. You follow up with cardiology. We're already going to be seeing them. They're already going to be in our pathway. We're going to be restricting them for 3 to 6 months from competitive activity and telling them gradual return to play. The reason is honestly because you don't want to put a muscle, the heart, that's just under stress, under more stress. Could you induce some kind of arrhythmia like a VT, VF? Could you cause worsening cardiac dysfunction? You don't want to tempt fate once you think about it like pulling a muscle, right? It's your heart and it's a muscle. AAP recommendations really break it down to kids less than 12 and kids over 12. Anybody under 12, they're probably not going to be doing like this, high intensity football, crazy competitive athletics to a certain extent. They can go back to sports or PE at their own tolerance. Kids greater than 12 need to do this graduated return to play protocol. AAP recommending the 7-day minimum progression when returning to exercise, watching for these symptoms and seeing, is this just deconditioning? Is this getting better? Let's say you fail one of these stages. One of the recommendations that they had was go back to the old stage. So if you had these 1, 2, 3, 4, 5 stages, let's say I'm tired at stage 2, I can't do it. Go back to stage 1 after a 24-hour period of rest, see if you can do that, and then gradually go back to stage 2. So you keep trying to see if the symptoms are improving. If they're not improving and you're really hitting a wall, then you're probably going to be okay. Then I probably need some extra help and assistance. These tables, this is from the AAP. There's a couple other tables from the AAC. We've got some references for you as well. And that is everything for you with our Lunch and Learn. So